Ramya Chellammal, working as the senior lecturer in the Department of Pedodontics. So today's lecture is on early childhood caries. So the contents of my presentation will include definition, etiology, its prevalence, the risk factors, the clinical classification, the prevention strategies, management and treatment options. So the primary teeth are very important in maintaining the space for the permanent teeth to erupt, which in turn plays a very essential role in maintaining the child's well-being. Dental caries on primary teeth can lead to chronic pain, infections and other morbidities. ECC is definitely preventable, but currently it affects more than 600 million children worldwide. The disease has a major impact on the quality of life of the children and the families associated, which in turn is an unnecessary burden to the society. So what is ECC? So the definition of ECC is prevalence of one or more decade, that is cavitated or non-cavitated, missing teeth, that is due to caries, or filled tooth surfaces in any primary tooth in a child under 6 years of age. The expert panel at the Bangkok Global Summit in 2019 defined dental caries as a term of ECC as a biofilm-mediated, sugar-driven, multifactorial dynamic disease that results in the phasic demineralization and remineralization of dental hard tissues, which are determined by biological, behavioral and psychological factors linked to an individual's environment. There were a lot of various names that were given before the terminology of ECC was established, and those are in 1911 it was first called as comforter caries, and in 1962 as milk bottle mouth. Later came terms like nursing caries, nursing bottle caries, baby bottle tooth decay, bottle mouth caries, milk bottle syndrome, night bottle mouth, maxillary anterior caries, rampant caries in infant, labial caries and incisor caries. So in the recent terminologies, all these are put together and now it is called as early childhood caries. What is the etiology of early childhood caries? It's a multifactorial disease. It is caused by interaction between the biological, behavioral and the environmental factors. So as you can see in the picture below, we have Keys triad, which we are all very aware of, which includes host, agent and substrate. But in the recent trends in the year 1982 came Newbrin's tetrad, where they had included time as well. So these four factors, multifactorial factors, play a very major role in the development of early childhood caries, and we are going to see one by one. So the first microbiological factor is the primary microorganism, which is Streptococcus mutans and Lactobacillus species. The first initial transmission happens only from the mother to child, and this is termed as vertical transmission, which can be by sharing the utensils or by a kissing or from saliva sharing or the pre-tasting the food before giving it to the infant. So this is the only way the S mutants can get into a child's oral cavity. So high bacterial load and frequent sugar intake can cause rapid acid production, which will lead to demineralization. The next important term that we need to know is something called as window of infectivity, which was given by Caulfield. So it's nothing but an age range during which children are at a greater risk of acquiring Streptococcus mutans. The set period is between 7 to 24 months, during which the primary teeth start to erupt in the child's mouth. So the first window of infectivity is from 19 to 31 months with a mean of 26 months. And the second window of infectivity is when the permanent teeth start erupting, and this is usually at 6 years of age. So this is the prime time at which S mutants start to colonize the oral cavity. The next major aspect is substrate, which is the dietary sugars. So frequent and prolonged exposure to fermentable carbohydrates such as sucrose, glucose, fructose can cause high risk of ECC. So at which age should the child be introduced to sugar is very, very crucial. Sucrose-rich diet can cause a fall in the pH, which can lead to a dysbiotic microbiome. And night bottle feeding, especially nocturnal feeding of milk or formula or any forms of sweetened juices or liquids, can cause a higher risk of ECC. On-demand breastfeeding beyond 12 months of age, especially at night, should be avoided. This picture here represents a frequent intake of a child having meals at very frequent intervals can cause the acidic environment to be prolonged for a longer duration of time, and hence we can see that the oral cavity never reaches the neutral acidity level. This puts them at a danger zone and more of a higher risk to ECC. The association between breastfeeding and ECC is another very important factor. Extended breastfeeding is a protective factor only if this is done under 1 year of age. If it's going beyond 1 year, then we need to conclude between the protection as well as the aggravating factors to caries, because the multiplicity of the compounding factors become very aggravated, such as the dietary patterns, the frequency of intake, the familial background, the countries of the originality, everything plays a very major role here. Breastfeeding that continues beyond 1 year, we need a consultant with the dentist specifically to prevent any form of ECC from occurring. Breastfeeding nocturnally also elevates the risk of early childhood caries in preschool children. Next is host factors. So we saw the microorganism, we saw the dietary factors, and now we are seeing the host factors. Tooth morphology, the production of saliva, and the eruption timing are the three main roles that have to play with the host. So tooth morphology is you have an hyperplastic enamel, if you have deep bitten fissures, if you have thinner enamel, these teeth become more susceptible to decay colonization with the microorganisms. Saliva, if you have reduced salivary flow, low buffering capacity, all this can affect the oral clearance rate. If you have early eruption of teeth, that means there is a longer exposure to the cariogenic bacteria, and this can also cause a lot of decay. There is a new terminology that has been introduced which is called as HASECC, which is nothing but hyperplasia associated severe early childhood caries. So this is a new terminology, and this is very evident in teeth where children have pre-exposure to hypoplastic enamel. That is, when there is a perinatal insult to primary dentition, this can cause enamel hypoplasia in these children, which is mostly caused when children have malnutrition, any dietary deficiencies, low birth weight, prematurity, pre and postnatal infectious diseases, and if the host has any other risk factors, these children get exposed to enamel hypoplasia. This can cause early and higher colonization of Streptococcus mutans and other cariogenic bacteria in these vulnerable locations of the teeth. This can again get aggravated when there is presence of cariogenic diet, which gets introduced once the child is about 1 year of age. So both of this put together will lead to a condition which is called as hypoplasia associated severe early childhood caries. So nothing but hyperplastic spots act as an early easy colonization for S mutants, which aggravates the process than when compared to a normal teeth. So next we are going to see contact areas. So when you have broader proximal contact areas, as we know in primary teeth, it increases the susceptibility of caries because the self-cleansing action reduces. So what happens, the classification of contact areas in primary teeth are of 4 types, which is known as Ox's classification. As the picture you can see, you have zero contact, which makes it open contact, so hence the term zero. Then you have a contact where you have X-shaped contact, making a score of 1. Then you have an I-shaped contact making a score of 2 and an S-shaped contact making a score of 3. So the score 3 denotes that the self-cleansing action is absolutely nil, and these teeth are very much prone to forming caries. The other 3 factors are behavioral factors, socioeconomic factors, and additional contributing factors. The various behavioral and parental factors could be lack of parental knowledge, poor brushing and flossing habits in the children or in the family, sharing the utensils or pacifiers with the siblings, any cultural feeding practices that puts them at a higher risk of caries, low socioeconomic status, which means their limited access to the dental care and education, very poor maternal education, and living in areas of low fluoridated water supply. Additional contributing factors is dipping your pacifiers in honey or jaggery or sugar syrup, chronic illness in a child which makes them more prone to higher amount of antibiotic intakes and sugary medications, and children with special healthcare need where difficulty in maintaining oral hygiene is always a question. So these are the various factors that can aid in the prevalence and etiology of ECC. What is the prevalence of ECC? How prevalent is it in our country? As you can see in this picture, almost majority of our South Indian population are at a lower risk, but the population over Rajasthan, Gujarat and Madhya Pradesh do have higher risk of ECC, which is prevalent, and the overall prevalence rate of India is about 49.6%, which indicates 50% of our children are affected with ECC. Next, we are moving on to classification of ECC. There are 3 types of classification where we have type 1, type 2 and type 3. Type 1 indicates mild to moderate, where there's existence of isolated caries lesion in a child less than 2 to 5 years of age. Type 2 is moderate to severe, where you have the maxillary incisors that are affected, whereas the mandibular incisors are not affected. We have type 3, which is severe caries lesion, which affects all the teeth including the lower incisors, and this is termed as rampant caries, and this classification was given by Wayne. Next, we have a clinical developmental stages, which is nothing but the clinical classification of ECC, which was given by Verkamp and Vergim in the year 1995. So this is the 4 stages. This picture denotes stage 1, which is an initial reversible stage, which usually occurs within 10 to 18 months, which is in correspondence to the eruption of the first primary teeth. Here you can see cervical and occasional interproximal caries lesion, which is chalky white demineralization, and the child will not have any pain, and this is termed as initial reversible stage. Stage 2 is damaged caries stage, which is from 18 to 24 months. Here the lesions in the maxillary teeth may spread into the dentine, and you will start seeing yellowish chunks of brownish discoloration. Pain can be seen only when the child is given any cold stimuli. Next is stage 3, which is a deeper lesion, which is mostly seen from 24 to 36 months of age. And the clinical features here are the molars also start getting affected, the frequency of pain complaint becomes high, and the pulpal involvement you will start noticing pulpal involvement in the maxillary incisors. Stage 4 is traumatic stage, where you have 36 to 48 months of age. The clinical features is the teeth become relatively very weak, and even small forces can fracture the anterior teeth. Parents will complain of any history. Molars will start having pulpal problems, that is, they might require pulpal treatment, and the maxillary incisors now would become absent or it will be non-vital. Next, we're moving on to risk factors. So the risk factors are a group of people who are at a higher risk of developing caries. So this is of 3 types. You can have social factors, protective factors, and clinical factors. So we are going to see social factors here. We have parents and caregivers who are a lifetime of poverty, that is, children are put under lower socioeconomic status are at a higher risk factors. Children who have frequent exposure of sugar-rich content, sugar-rich snacks, sugar-rich beverages are again put at higher risk. Bottled milk or formula milk, which is being fed at nocturnally, which is at bedtime, or breastfeeding beyond 12 months of age, all this puts the children at higher risk. Mother and primary caregiver having active dental caries, if they are being sharing the utensils, then it puts the child at a higher risk, and children with special healthcare needs. Clinical factors is like we discussed earlier, if they have any non-cavitated lesions or enamel defects, if they have visible cavities or fillings or missing teeth because of caries, and if they have visible plaque in their dentition, this puts them at higher clinical risk. Protective factors which can balance out these negative factors is if the child receives fluoridated drinking water, if the child brushes daily with fluoridated toothpaste, if they receive topical fluoride application from a health professional, and if they have a set dental home or a regular dental care, this will put them at a lower risk of getting any form of early childhood caries. So how do you assess if the child is at a high caries risk or low caries risk? There is something known as caries risk assessment, which is CRA. So these are nothing but a process of establishing the probability of an individual or a group of children who develop caries lesion over a certain period of time, grading them whether they are at higher risk or at a lower risk or at a moderate risk, depending on their clinical conditions. So could be of 2 types. It could be of a manual form or an algorithm form. The manual form is the IAPD CRA and the CAMBRA, and the algorithm software programs are Karyogram and NUS CRA. So this picture here is the AAPD's American Dental Association's CRA form, which is manually filled by the dentist. Depending on the questions that are put forth in this chart, we would overall assess and decide whether they are at a higher risk, lower risk, or at high risk, and in turn put them into their various form of treatment plans. So how can we prevent ECC? So prevention of ECC could be of 3 stages. We can have primary prevention, secondary prevention, and tertiary prevention. So primary prevention happens in the first place even before the child is born. We would educate the parents and the caregiver, the nurse, the hospital environment where the child gets their initial exposure, the pediatrician. All of them should be exposed to various preventive guidelines in terms of early childhood caries. The secondary prevention happens when you detect early caries, and then how could you not make sure the other teeth get prolonged with this. Tertiary prevention happens when you have established dental caries and you require any repairs in order to re-establish the oral status. So primary prevention is timely delivery of educational information and preventive therapies given to the parents and caregivers even before the child is born. Physicians, nurses and pediatricians may have the opportunity to meet these parents even before they meet a dentist, so they should have exposure to all these preventive strategies. Optimal exposure of dietary fluoride like fluoridated water, fluoridated salt and fluoridated milk should be given to dentate infants. Topical fluoride application can be done by home by brushing twice daily with fluoridated toothpaste. Ideally, a child should make their first dental visit within 6 months of eruption of the first tooth. So by establishing this, they get a periodic evaluation as well as the strategies could be met in order to prevent ACC. Secondary prevention happens when you notice there are already primary cavitations already seen in the individual. Then it goes to secondary prevention, which is the process of stimulating regression, that is remineralization. So early detection of incipient caries can definitely prevent further damage. Hence you can do fluoride varnish applications, pit and fissure sealants as well as glass ionomer cements. Next is tertiary prevention. So this happens when you have established cavitated enamel lesions, dentin lesions already present in the individual. So you can have both non-invasive as well as invasive strategies. The non-invasive strategies could be silver diamond fluoride, which is nothing but application of this on the cavitated lesion even without removing the dental caries. Then we have ART, which is nothing but atraumatic restorative treatment, which is nothing but removing without the drills and filling it with GIC. And for any multi-surface lesions, we will always end up putting direct crowns. So this is the latest guidelines that says the management strategies for ECC, which was developed in the year 2019. Here you can see the ICC-MS 4D caries management system, that is detect, determine, to do and to decide. So by doing all these 4 Ds, we will be able to eliminate as well as manage ECC. Next we are moving on to evidence-based preventive measures to detect and decrease the development of ECC. So step 1, you establish a dental home even before 6 months of the child's age, no later than 12 months of age. That is, it should coincide with the first erupting tooth. Next, you delivery of anticipatory guidance in terms of parental brushing, any age appropriate instructions, the volume of the fluoridated toothpaste to be used, all such things must be included in the anticipatory guidance. Next is professional fluoride varnish application if the child is at a higher risk of ECC. Next important thing is dietary counseling. The child and the caregiver and the parent have to be given dietary counseling advices, which could be avoidance of any nocturnal baby bottle and breastfeeding after 12 months of age, encouragement of increasing the water consumption, that is 4 ounces to 8 ounces of water per day, which would compensate from the juice consumption that the child would ask for, avoidance of foods and drinks with extra added sugar in child less than 2 years of age, and complete restriction of 100% fresh juices and reconstituted juices until 2 years of age. All this can be compensated by giving water. That's what the IAPD guideline recommends. And avoidance of frequent consumption of sugar. That is, in between meal snacking should be avoided in a child less than 2 years of age. All this would, if followed, would put the child under lesser risk of developing an ECC. So what could be the various treatment modalities? So in preschool children, if you have minute class 1, class 2 lesions, they can be filled with glass ionomer cements as well as resin modified GICs, which could be considered for occlusal, class 1, class 2 and class 5 lesions. Because of high fluoride release and the remineralization property, GIC is anytime preferred over resin modified resins. Then we do have resin modified GICs, which could increase the aesthetic requirements of the patient. And then we have full coverage crowns, which could be necessary for restoring the ECC patients where there is extensive tooth loss. And we have resin based strip crowns for the anteriors in order to remark the aesthetics. So this chart here depicts the entire treatment plan that could be done for the child, classifying into non-cavitated lesions, cavitated lesions, children at higher risk and children at lower risk. For primary prevention happens with diet, with toothbrushing, with pit and fissure sealants and professional fluoride, as you can see in the picture. Then they have defined it into non-cavitated and cavitated. The non-cavitated approach, as you can see, there's pit and fissure sealants, topical fluorides, resin infiltrations and STF. Minimally abrasive techniques, we have ART, ITR and SDF. Then we have mixed approach, which includes Hall technique. And then our normal traditional restorations and crowns and amalgams and composites come under traditional approach. So this is a chart that can be followed as a management strategy. So this brochure is what has been advocated by the IAPD, which is the International Association of Pediatric Dentistry. This is the latest guidelines, and this is a brochure that has been circulated to all the pediatric dentists, to the practicing dentists, to all the pediatricians in order to create awareness. As you can see in this brochure, we have 4 factors. Factor 1 is raising awareness for the parents, caregivers, dentists, pediatrician, nurses, all the other healthcare professionals. Step 2 is creating awareness to limit the sugar intake for a child less than 2 years of age. Step 3 is to perform brushing twice daily using fluoridated toothpaste, which is less than 1000 ppm of fluoride, and age appropriate toothpaste amount. Step 4 is to provide preventive guidance. That is, you need to have vaccinations, you need to have ideal dental visits, you'd establish a dental home, and all these 4 strategies would aid in preventing early childhood caries. So with this we complete this early childhood caries. As a summary, as we know, we have seen the definition, we have seen the prevalence, we have seen the etiological factors like the host, the agent, the substrate and the time. We have also seen the prevalence in our country is about 50%. We saw the classification of ECC, we saw the clinical classification, which is divided into 4 stages. And then we came into the risk factors. We also found out which group of children are at a higher risk and a lower risk. Up next, we saw caries risk assessment, how we could actually grade these children into various risks. And then we saw how we can prevent ECC with primary, secondary and tertiary management. And then we saw the management strategies which are given in the latest IAPD guidelines of 2019 and evidence-based treatment plan. So like I conclude, prevention is anytime better than cure. So as early as possible, if we can identify and treat these children, their likelihood of the entire family and the health of the child will improve by 10-folds. So I conclude by saying, try and we could reduce the gratitude of effect this early childhood caries can have on the child. Thank you. I will get back to you with another lecture.